Ladies and gentlemen, it's an absolute pleasure to be here. It has been an incredibly exciting day. I know I have learned a lot, and I'm sure you have too. But what better way to round out the day than to get to talk about generative AI? I think that it's hard to go a single day, at least in my life, without having the privilege of someone telling me it's going to change the world. So now I'm going to take up an hour of your time, getting some real experts to tell you whether it will or it won't. So how we're going to run this afternoon is we are going to be done in an hour sharp so that I do not get daggers from the organizers, and then I can get you off to enjoy the revelry this evening. On the slide behind me, you will see all of our phenomenal speakers and panelists. In a moment, I'm going to invite them up here in turn, both to present the work that they're doing and then for us to have a conversation. If I'm smart enough, I will have put the QR code slide up. No, I'm not smart enough. Sorry, Jay. No one look. The way that this is going to run is I have created a set of questions. I've given them to the panelists. The conversation that we have this afternoon can be entirely orchestrated by me or by you. So that QR code that you see up on the screen, you've been introduced to at least once today. If you take out your phones, and this is the only time I will encourage you to take out your phones and take a snapshot or log in. If you submit your questions, I will be monitoring them throughout the course of the afternoon. And if someone asks an interesting one, I will decide to forego one of my very profound questions for one of yours. So the decision is entirely in your hands who gets to interrogate our panel this afternoon. Now, if you close your eyes again so that I can go back to the top and not ruin Jay's slides. We're going to kick off. So I'm actually quite embarrassed to admit that I did not know the two organizations that I'm about to ask to get up and present in a moment. That is entirely my fault, and it's not a reflection on them. They've been doing incredible work far longer than I, especially in this space. And what we're going to start with is a presentation by Jay Patel, who is the Director of Technology at Jacaranda Health. Jay leads the technology strategy for Jacaranda. He's helped expand healthcare accessibility for millions of mothers across sub-Saharan Africa by presenting and implementing projects exactly like the one he's about to tell us about, using open multilingual African LLMs to enable access for pregnant women all over sub-Saharan Africa when they're in need. So Jay, if you would join me up on stage, please, and everyone, if you'd join me in welcoming Jay. You're fantastic. Thank you.
So much for Director of Technology. All right, so I'm going to speak about how we use AI to help support millions of mothers across Kenya and sub-Saharan Africa. Start out with a story of Millicent, who is 8 months into her second pregnancy. She lives an hour away from the nearest health facility, and she doesn't own a smartphone like we all do. She owns a feature phone like the old Nokias. She cannot do what we all take for granted. So if we want information or want to Google something, we can just pull out our phone and do it. But on a feature phone, no WhatsApp, limited access to the internet, you can't do that, and you don't have access to the information that most of us do. So during her first pregnancy, Millicent experienced preeclampsia, which is high blood pressure. She experienced severe headaches and also blurred vision. She didn't realize that this during pregnancy was a danger sign. She couldn't just look it up on her phone. And so she delayed in getting to care. That delay, unfortunately, resulted in a stillbirth. Now, fast forward to her second pregnancy, where she gets on our platform called Prompts, and can ask any questions she has, all for free over SMS. So no WhatsApp or no apps required. The delay that Millicent experienced, she's not alone. 1/3 of maternal deaths in Kenya happen basically due to delays in seeking care. So when I joined Jacaranda, Millicent and moms like her were asking us about 100 questions a day. As of a couple months ago, we're getting between 10 and 12,000 questions every single day. And a human-only help desk at this scale is no longer relevant or a sustainable way of handling the questions. Most of the questions we get are benign. A common question is, can I eat avocados when I'm pregnant? But about 7% are potential danger signs. Moms are not also texting us in university-level Swahili, right? They're using informal Swahili. code mixed with English and Sheng, which is a fast-adapting, fast-moving slang. They have feature phones, so they're sending abbreviations and texting us in like local colloquial language. So I'll give you an example. A mom had messaged us, she's pregnant, she messaged us about, in Swahili, her question was about a baby playing, but what she meant in reality was fetal movement, so the baby or the fetus in the abdomen kicking and moving. We ran that question through ChatGPT, Gemini, and they all answered literally about a baby playing, which is in the context of the question was incorrect. So we developed our own language model. We took Meta's Llama 3, fine-tuned it in 2 steps, first for general Swahili, and then that model is called Uliza Llama, that's open and free, anyone can use it, and fine-tune it for their own purposes. We took that model and then further fine-tuned it for our use case so that it can help respond to the 10 and 12,000 questions we get every day. This model handles about 70% of the questions we get. The help desk then can focus on the urgent ones, which is, we're flagging about between 10 and 30% of the questions which are urgent. The good news is that no one's lost their job over this. The help desk can now get to apply their human intelligence to where it matters most, to the urgent questions. Nobody's lost their job over it. And also, Millicent had texted us in, again, a question about high blood pressure, about severe headaches. In this case, our AI was able to pick it, send it to the help desk. They called her and told her to get to a hospital immediately. And happily, a month later, she delivered a happy, healthy baby boy. Thank you.
I don't know about you, but that story that Jay just shared about a woman asking what she should do if she can't feel her baby playing is one that stuck with me ever since I first heard Sathi is one of the executive directors at Jacaranda sharing it. And I think it demonstrates just how much further we have left to go with this technology. I was actually standing at the back today and saw someone typing in a question into Gemini. I think we've all found value in this technology in our day-to-day lives, but as we think about that phrase of no one left behind, it could be so easy for us as we move ahead with how innovative this technology is to genuinely leave a lot of people behind. And on that note of not leaving people behind, I want to invite up our next speaker. So Hannah is a public health professional. She currently leads research at MDoc, ensuring data-driven, evidence-based, and evidence-generating activities are woven throughout the portfolio. I'm going to invite her up to share with us a little bit of her experience of trying to leverage large language models in the context of MDoc's work, which is virtual self-care. Hannah, all yours.
Hi, good afternoon, everyone. I'm Hannah Manai, and it's a pleasure to be here. Let's see. Okay, so I am representing MDoc Healthcare. MDoc is a digital health social enterprise based in Lagos, Nigeria, and we provide end-to-end virtual self-care health coaching for people with regular health needs, such as hypertension and pregnancy and chronic health needs such as hypertension or diabetes. And we do this through leveraging quality improvement methodologies, data, technology, as well as behavior science. We have to date, over 129,000 members on our platform, majority of whom are women. So we measure success and impact through multiple metrics, including self-efficacy, so the confidence in being able to manage your health. But for today's purpose, I'm highlighting some of the clinical metrics that we look at to measure impact from the perspective of cardiometabolic indicators. So we really look to achieve reduction or maintenance of blood pressure, blood glucose, as well as positive impacts, increase in proper nutrition, as well as active minutes, for example. So in 2020, during the pandemic, during the pandemic, there was an increase, obviously, in the needs of, in the health needs of people, and decrease in access or hindrance in access. And due to this, we decided to add our coaches. sorry, I forgot one important part, which is the channel through which we deliver our self-care health coaching is a four-pillar approach, but for today's purpose, I will only highlight one, which is our web and mobile-based platform called Complete Health. This is how our members are able to manage their health and interact with our health coaching methodology, and mainly health coaches, human health coaches, who we have on the other side of that application. And these coaches provide nudges, they provide health navigation and health information, they also do motivational interviewing and other coaching aspects that are related. And so during the pandemic, the coaches got extremely overwhelmed, as did the entire health system, so did the coaches. The breadth and depth of the questions and the support that they needed was well beyond the remit of what they had been trained to provide, as well as it coming in around the clock. And so that's when we introduced a rule-based chatbot at the time, named Ken, to provide if-then sort of answers on specifically hypertension, mainly due to the prevalence of hypertension in our member cohort. And obviously there were limitations with the rule-based architecture, mainly that we couldn't scale it, we weren't able to introduce multilingual support, and the depth of the conversations, the conversational depth was quite shallow. And so luckily, we were able to secure the Grand Challenges Award for last year in 2023 for catalyzing equitable AI use in global health. And we decided with this, let me move on to the next one, we decided to introduce ChatGPT and through an observational study, see how we could leverage LLMs to broaden the support that we provide through our chatbot, Kem. So we introduced ChatGPT into the architecture, and we gave Kem two agents. One is a virtual Q&A coach, so able to answer a wide range of questions, although it was mainly trained on for four health issues: maternal health, neonatal health, family planning, and STIs. We obviously the LLM allows it to cover and run a conversation, multi-round conversations on a breadth of topics. We also designed a second agent, which is its ability to serve as an intake coordinator, which is specifically designed for pregnancy and to both identify the pregnancy stage of pregnant women, that's trimesters, and also the risks associated with from social determinants of health to pregnancy history, etc., and it runs through conversations to end up determining the risk level of the user. And so we also provided instructions for Kem to reflect the persona of our human health coaches and our methodology more broadly. So we were able to do this through what we like to call a clinical approach, which is the joining together of our clinical and ML teams. And we worked together to iterate on the model building, but also as we were iterating over a 9-month course, this specific study, we were able to have our research and project management teams go out and run rapid cycle user testing with women of reproductive age, both in controlled settings as well as uncontrolled settings in markets, for example. And we were able to see a serious improvement in the metrics most important and central to our study, which were accuracy, empathy, and then here we also have safety and contextualization, so its ability to reflect the language of the users and the needs and conversational styles of the users. And so I would attribute that jump in score mainly also to going from using GPT 3.5 to 4, and then also just an improvement in our prompt engineering. And so we also, don't know if I have time, we also run a side experiment to see how well our coaches and other frontline workers were able to leverage GPT as a resource to answer and to improve their responses that they generated for health queries for women. And we saw, we had an external blinded clinical panel able to evaluate the quality of the responses both before the use of GPT and also then including GPT, and we saw a marked improvement 1 to 5 Likert scale, statistically significant, which we will be publishing on very soon. But this was also very important for us to understand the relationship of how not only GPT could support our members, but also how could it improve and make more sustainable our coaching. Finally, most recently, we were able to integrate speech-to-text and text-to-speech technologies into Chem in our application Complete Health, and run a small beta testing and saw some promising results, and obviously we're able to highlight the major issues with that. But in general, we had improved use even after the end of the beta testing. So now we're at the stage where we want to, that was a closed beta, now we're looking to have a more broader beta testing, and obviously we are really looking forward to partnering with University of Birmingham and PATH in order to run our evaluation clinic, or participate in their evaluation clinic to improve our evaluation and work towards validation and launch. So yeah, thank you for listening to my presentation, and happy to take questions later.